Hey guys, welcome back to another episode of The Skeleton Crew. My name is Jen Callahan. Tonight, I have a great guest with me. His name is Wesley Shay, and he's a radiology assistant at one of the leading cancer centers in the country at Sloan Kettering. So, Wes, thanks so much for taking the time to be with me tonight.
Thank you for having me.
Wes, you're actually the second rad assistant that I've had on the show, and it's a growing profession. So I'm excited to have a conversation with you just to get more answers and, share what's going on in that part of radiology with our audience that's listening. So can we just start with like a background of yourself? Like, where did you start out at? And then how did you find yourself where you currently are now?
Absolutely. I started pretty much like every RA, initially as an X-ray technologist, and this was about 12 to 14 years ago now. And throughout my education, I developed an interest in the OR setting and didn't really know where that was going to go. But as I began, there was rumors of the RA program beginning, and I was lucky enough to become accepted into the first class through Quinnipiac University. I graduated from there and was able to get a job at NYU Langone Medical Center. It was the initial job there, so it was kind of rough in the edges trying to figure out what I could do at that start. And then after that kicked off for 3 years, I moved on to Memorial Sloan Kettering Cancer Center, where I've been for the remainder of the time, about 12 years now. And it's been great. We've been continually expanding. We have a great number of people now. So it's kind of a branch off of the technologist role, where I got my footing and where most of the RAs get their footing.
So when you were saying that you were in the OR setting and you were kind of like at a crossroads, like, where is this leading me to? What sparked the idea of looking into being an RA?
I really just liked the OR setting. I was always fascinated by, everybody kind of get a little bit more amped up, so to speak, about the day's work and the equipment, and obviously involved in the C-arms and the orthopedic type stuff. And I didn't have the energy to look at MD or anything like that for physician, but I saw somebody put it in a Mediport at an outpatient facility and thought that was fascinating. And at the time, didn't know that that was what I could be doing and is now what I am doing. So I kind of just continued to drive my interest about the surgical technique and the sterility of procedures.
An RA, I guess, can have many different roles within radiology, but that's the kind of route that you've gone with being a rad assistant, is that you're doing more surgical procedures?
There really is two routes. We kind of refer to as the diagnostic route or the procedure route. And luckily enough, at my facility, we have 15 RAs. A little bit less than half are in the diagnostic area. And then the part that I'm in, with the 9 of us, we do the interventional radiology procedures. A lot of them are the venous access type cases that I originally learned to do. And those can be anywhere from Mediports, tunnel dialysis lines that we use for blood transfusions. We've been able to be trained and educated while we're there to do biopsies, routine tube changes, a lot of the, I wouldn't say simpler type procedures, but a lot of the things that the expertise of the radiologist isn't necessarily needed for, so they can put their attention on the big cases like the embolizations, ablations, things like that. So the IR is really what I was attracted to. And then the other aspect of what the diagnostic side does is like the protocoling and the image formatting for the radiologists.
Image formatting, what do you mean by that?
Making sure that the correct protocol is done. So if a referring physician doesn't quite know what they want, or a lot of times residents or fellows don't necessarily know what type of procedure they want, the radiologist assistant is a great person to refer that information to, so you don't have to bother the radiologist, interrupt them from reading a cardiac CT or some other type of big exam. The RA can just use their education to say, yeah, you need this abdomen CT with or without contrast. So it's a great avenue from that aspect.
That's interesting. I have to say that from the last conversation that I had with the last person, I didn't really catch on that there was 2 different roles of what an RA could do. And it's interesting because obviously someone who likes to be more hands-on, I'm assuming like yourself, like with the surgical procedures, or someone who is more so interested in the imaging portion of it, that's nice that you have those 2 routes available.
Yeah, and there is some blending throughout the country of the positions. My group really just has a pretty clear defined line. Again, we're in New York City, so we have the availability to have a mass number of people. But you head down south in Virginia or out in the Midwest, and you could get some people that do paras and thoras, as well as upper GIs and swallow exams and the barium type stuff. That's the other avenue, is like the fluoroscopy type procedures. Those are really geared towards the diagnostic group. So there's almost 3 branches of it, but really 2 definitively.
with the growing number of, I guess, like sick people out there or even procedures that are being done, it's great that the radiologist has the help of the REs to help alleviate that work and spread it out so that, like you said, they can focus more on the tougher procedures or reading different exams.
There's definitely, somebody phrased it to me as, obviously everybody knows about burnout, but fatigue is something else that somebody said, like they phrased it as a different phrase that I can't remember right now, but it really is use them to their skill set and then allow us to be used as our skill set, all within the encompassing radiology department.
So radiologists in my department, like you said, they almost get pulled in so many different directions between they do like fluoroscopy or they work in our department. I am in interventional radiology, but we do have techs from the x-ray side come in and they answer a radiologist, can you come in and do a fluoro procedure? But then they're also too looking at a CAT scan of something. And then they're also too waiting to start whatever procedure that they have coming into the IR suite next. So it's great that the RAs are there, at least in your facility, to help alleviate that fluoro procedure and or doing whatever the procedure that might be going into the IR suite next, that maybe if we had RAs, they would do it. But because we don't, we do have physician assistants who do procedures such as that, but it seems like you guys might do more than what the PAs do in my hospital.
Yeah, I think what you were alluding to earlier too is we don't diagnose. That's left up to the radiologist. I mean, they have 5 times the amount of schooling that we do. We work under their supervision. So the biggest thing is they're supervising us dependent on the level. Regarding CMS, which I won't get into, but there's personal, direct, and general supervision levels. So depending on the hospital standards as well as the CMS requirements, we're allowed to do things at a certain level. We're always under their supervision. We're always performing or doing things under their guidance, but it's a huge relief to them to not have to do certain aspects of the radiology department when they can be doing something else, again, that requires their expertise. Yeah. And I do think it is facility dependent. We have at least 9 of us, and there's 7 on per day. So it's not like we're minimum. We're not like, oh, there's 2 on and 5 off. We're all very, very busy. One of the biggest things that we do is any procedure that gets referred to us, to the IR department. So if a patient has breast cancer or lung cancer and they need a procedure done, we're the first line of the offense, I guess. They say, hey, this patient has this, we need a procedure. We review it. We look at the blood work, the imaging, the allergies, their location, because we have 5 different centers. So they could be out in Long Island or Connecticut, depending on where they live. And we kind of correlate all that and then present it to the radiologist, the cliff notes, and say, here's the situation. This is the case. It alleviates probably 10 to 15 minutes of work per patient. And that's how we also decrease their burden of work. They can be consulting another patient while we're reviewing 2 or 3 other patients and then, work in collaboration with them. Again, all under their supervision, but that's how we get our patients in the system.
I want to go backwards for a moment when you talked about schooling and, how RADs have 5 times worth the amount of schooling that you or I possibly had. But to become a radiology assistant, what does that look like in terms of schooling?
They change it about every 3 to 5 years through the ART. Now it's a 2 years master's, but you have to have 2 years of clinical experience prior to that. And you have to have an RT license.
Okay.
So obviously you can't have a bachelor's in karate and then you want to go get your RA license. You could have a bachelor's in biology and still have your x-ray license, but you have to have both the bachelor's and the RT license, and then have 2 years. They changed it. It was 1 year, now it's 2. It's been a year now, starting 2023. And that they just wanted to kind of get more people with more experience. But then in addition to that, the ART requirements during the school is over 500 cases that we do as part of the clinical experience before we take the boards. And that is where our heavy hitters are, that we have all this experience prior to graduating, prior to other positions. And that also includes the thousands of hours that we do. We do 2,000, 3,000 hours before we graduate of clinical time. It's a big advantage to have all that time. You could walk in the door and you don't have to say, this is where you have to mark for a paracentesis. You know, to say, oh, you've done 25 of these. Okay, please go do one. So it's a big training aspect as well.
This episode is brought to you by xraytech.org, the rad tech career resource. If you're considering a career in radiology, check out xraytech.org to get honest information on schools, degree options, career paths, and salaries. So the required procedures that you do, are there like you had to do an abdomen, you had to do a chest, you had to do this, and there was a certain amount that you had to have done. You had your required ones and then you had so mandatory, and then there was like the elective exams that needed to be done for you to be able to sit for the registry. Is that something similar to become an RA to sit for the registry?
Exactly. There are mandatory and elective procedures, and the mandatory are pretty much where everybody gets their initial scope of practice when they get employed. And the mandatory consists of the fluoroscopy procedures, such as the upper GI, esophagram, barimenema, some arthrogram type stuff where you do the needle work, and then things like the paracentesis, thoracentesis. So you get to learn the smaller stuff before learning the big stuff. But then once you get into the field, you can be trained and educated to do much more, obviously, which is what we're doing at our facility. And there's certain numbers, the esophagram may be 30 cases you have to do of those. A PICC line may only be 15, but there's a minimum. So you can't, unlike the x-ray program, you can't count, once you do one KUB, you do another KUB, now you have two. If you do 10 esophagams, but you have to have a minimum of 15, you can't count those 10 until you get to 15. So there's kind of some discrepancies there, but it does really require you to become minimally proficient in the procedures and the exams prior to your graduation.
So how do you feel with being an RA at Sloan Kettering, with it being a cancer center? Do you find that you're doing more type of exams than others because of the, patients that you have? Like, not to say clientele, but for cancer purposes.
Yeah, I think we definitely have a niche of, at least because I'm in IR, obviously focus on that. We have a niche of venous access type cases, routine tube changes. Like if a patient had had bladder cancer and they had bladder surgery, they now have to have a tube in their kidney, or depending on the patient, but a tube in their kidney, and they have to have it changed on a routine basis. Mm-hmm. And so that, that's something that we do every 6 weeks, 8 weeks, depending on the patient, whereas another facility might not have it. And the venous access type of procedures, there's so much that is required from a venous access device that there's so many venous access devices that are needed in the facility. And therefore, we kind of get pretty quick at doing the procedures. Not to say that we're extremely proficient at it, but we do a lot. And there could be, for RA, you could do 6 a day easily.
You said how you change the tubes out. Are you allowed to place them?
Depending on especially like post-op complications, if there's like a seroma or an abscess, depending on the comfort level of the physician and the experience of the RA. We have a couple that have just graduated and they're very good, but they're only been there for a year or two. And then myself and a few others have been there for 8, 10, 12 years. So there's the range of the comfort levels, and the physician, there's some people now that are attendings that were fellows, came through us 5 or 6 years ago. And so it's funny when, off in a tangent now, but we would train them when they were fellows and now they're our attendings. Right. So they're just like, yeah, you go do your thing. Again, all under the supervision of them, we can do different levels of things. And they may just be like, yeah, that's a big abscess, you go place the tube. They're absolutely supervising us, 100% legal, but they're different levels of supervision. Whereas the venous access type stuff, some of the physicians prefer us to do it anyway. So it works out really well.
So speaking of like neuro-IR and doing, different procedures like that, do you find the technology that you have at your facility, is it pretty extensive compared to other places that you've worked at?
We definitely have 15 rooms, and half of them are the combination CT floor rooms where the CT machine moves in and out. And so if we have to do something that requires the CT scan, but then turn around and do an angio in the same room, we have that capability.
So you have an actual like CT machine in the room with the IR/CR?
Correct. We have 9 of those.
Wow.
And we're actually, next month, we're blowing 2 of them up and putting in a whole new system in. It'll be the same set. But that's what we have. And then we have 2 regular C-arms. We have something that is massive at our center is we have 2 PET scanners. We can do PET guided biopsies. That's just our IR procedure room. There's not just, we need to do a head-to-toe PET scan. It's like, no, we have 10 cases scheduled. We're doing 10 biopsies. 6 of them may be PET guided. That's something that not everybody has.
So when you're doing the CT or like PET guided biopsies or whatever you might be doing that you're doing in conjunction with the regular IR procedure and then in conjunction with PET or CT or something else, Are you having another technologist there in the room with you besides like an IR tech? Like, do you have like a CAT scan tech who's running the CT machine for that or for the PET?
The majority, I'd say 95% of the techs are IR techs that are trained as CT. When we do the PET injection, we sometimes pull up the nuke med technologist because it's a little different with the sequence, and then we have to overlay the PET imaging onto the CT. So that gets a little tricky, but still very thorough and rapid. All of our techs are trained in the CAT scan.
Is there certain types of cancers that you're looking at that you would be using the PET with IR?
It kind of depends. There's cancers that metastasize and they light up on the PET scan, but you have the CT scan and you can't see anything. So we could use landmarks sometimes, but sometimes we can't. Like you may be able to count which rib it is, but you're not sure exactly where it is. Or it may be in the iliac bone and there's no correlate to the CT, so you need the PET guidance. Sometimes liver, kind of depends on the disease process.
Do you find more cancers prevalent that you deal with than others?
We have the capability of dedicated medical teams. And so there's doctors with some 25 some odd physicians in our IR group, and they specialize in a certain area. So we have one doctor who really spends his time on colon cancer. Okay. So he's big into liver treatment for liver mets. We have another doctor that's really big in lung cancer, so treating the lung cancer. So it's hard to, depending on the day, and their schedule rotates, there's no specific days, but depending on the day, there could be more of one type of disease than another. But as well as the referring physicians, we could see one day where we have 5 biopsies that are colon cancer, and the next day it's breast cancer that is metastasized. And I think it's just because the way that their clinic runs kind of populates on another day. I do think that there are cancers that we're getting successful at treating better than others. I think the lymphomas are getting better treatment. Breast cancer, there's obviously some that still just destroyed patients, but I do think we're making headway on that.
And with the lymphoma, is it better diagnosing, do you think, or is it the treatment that's getting better?
I think it's probably the treatment that's getting better.
Do you guys do any types of treatment within the IR?
They do the procedures. Again, depending on the disease process, they do like the Y90 or the chemoembolizations. So definitely dependent on the disease process and the physician who's going to be doing it. They're really big on collaborating with each other and planning out a process. So, and it's gotten more so in the past few years. We've gotten a big group of younger guys and girls, bigger group of younger physicians in the department that have really sort of branched out and done well, expanding the possibility of treatment.
So Sloan Kettering is a research institute as well. So I'm sure lots of work going on there and passing them along to the physicians that are treating the patient. So they're getting firsthand information, which I'm sure is monumental in treatment.
I think because it's so big, there's a lot of outside funds that come in and say, I want you to research this disease. Here's however much amount of money. So, okay, now I have this money. I'll go research that. So I do think that helps them a lot.
So you've been in the role of an RA for quite some time, and you obviously have seen the gambit of what's out there and always more to see because things are always changing and there's always something new that comes across your plate. But for those in the radiology field who might find themselves in the position of where you were in the past, with knowing that like you just wanted to do something else, what would be your advice to a fellow technologist?
I think the biggest avenue would be find someone that would push you and help you in that same aspect. Ask questions. I think that if you find someone that is willing to answer those questions, then you can ask more questions and then keep going from there. I think also the big thing is to network, get involved with certain aspects and network. That's helped me very well. And I think that helps lots of other people as well. You may not know person Z, but you may know D, G, and L, and they may know T, who finally knows Z. It's a smaller field than people realize. And even in the 12 to 15 years that I've been in the radiology field, I've gotten to know some pretty big names and gotten to meet a lot of pretty cool people and been involved in a lot of stuff. Definitely think networking is an underrated avenue that people need to look into. Even, can't even tell you how long ago it was now. I was part of a committee and sat down to dinner and was talking to the person across from me, and he knew the person that I had just completed a big project with. It was very interesting to then, now I still talk to that person. I saw him a couple months ago. So it's interesting definitely to see how you meet people and who knows who.
Are you happy with your choice to transition into the RA field?
It's a very loaded question. In short words, yes. I love what I do. I love the coworkers that I have in my group. And has it been easy? No way. There's about 500 of us in the 600 of us in the RA world. And I bet more than half would say they wouldn't do it again. That might be a false statement, but we've had a lot of struggles over the past 40 years that the RA has been around. I still try to fight hard. I know a lot of people are fighting hard to get the recognition that we deserve and desire. I do enjoy what I do, but it doesn't come out without the scars that we have. But it is an enjoyable profession. And luckily for me, where I am, my work has helped me make it an enjoyable profession.
So many people that I speak to on this podcast talk about how they're trying to develop things and technologies and stuff to help with the fatigue, the burnout of the radiologists and even for technologists. So, I mean, you guys are right there in the forefront with them, helping them out. So that's great in my eyes.
Yeah, I think that if anybody is interested in it, pursue it. Don't shy away from it. There's a lot online, some forums that people get a little feisty on, but I'm always in favor of, if you want to be in radiology, go into the RA field. I do think it's a great field.
Is it more responsibility than what you knew it would be going into it?
Yes. And I think also because I was part of the first class at my university, so none of us really knew what we were getting into. And I think that we kind of learned on the fly. And I think also different facilities will utilize their RAs differently. So if you're a student in Texas, you may have a different experience than a student in Utah or in Florida. So it's definitely where you are located. You have the ART guidelines to help you, but your experience still may be different.
I feel like that could even be hospital to hospital as well. You know, that certain hospitals do certain procedures in this department as opposed to doing them in that department.
Absolutely. Even within my clinical experience as a student, we had to rotate. We had the luxury of being able to rotate, but because one center was much more heavy on the fluoroscopy, we were able to get all the barium studies. And then another facility was heavy on the IR, so we were able to do that through that. So it's definitely center-based as well.
Yeah. I mean, even in terms of like when I worked in the X-ray department at a certain hospital in the city, we did the lumbar punctures and the myelograms in the X-ray department, as opposed to, I know that the majority of them are most likely done within an IR suite. So it's just interesting how, like you said, depending on the state, the city, the hospital, wherever you are, things are just kind of done just a little bit different.
Absolutely.
Well, everybody, this is Wes Shay with me tonight, sharing with us his experience of being an RA at a great facility, Sloan Kettering. So Wes, thanks so much for taking the time to be with me tonight. I really appreciate it.
Thank you for having me. It was great talk.
All right, everybody, catch us again on another episode next week. We'll see you later.
You've been watching The Skeleton Crew, brought to you by xraytech.org. On the next episode, join us to explore the present and the future of the rad tech career in the field of radiology.